So first thing that you need to understand about acute rheumatic fever, that this is not an infection, rather it's an immunological reaction, multisystemic immunological reaction, inflammatory reaction that follows an infection, and that infection is group A streptococcal pharyngitis typically. So it's basically a non-suppurative sequelae. Non-suppurative means it's not associated with pus formation. Sequelae or complication of group A streptococcus infections, typically pharyngitis. And it usually it's what is this basically then? It's an immunological reaction. It's a type 2 hypersensitivity reaction, and it's a immunologically multimediated multisystemic reaction which can occur in various parts of the body, involving heart, that is CVS, involving skin and soft tissues, involving the joints, which is a musculoskeletal system, and also involving the brain, CNS, that's usually associated with Sydenham's chorea. So in a nutshell, acute rheumatic fever is a multisystemic inflammatory disease which is an immunologically mediated reaction which follows a group A streptococcus pharyngitis typically. So it's a non-suppurative sequelae or complication of group A streptococcus pharyngitis. It's not an infection directly by the group A streptococcus pharyngitis, group A streptococcus. This is a very important concept reaction you need to understand. Rather, this is a immunological reaction which follows that infection, which occurs as a complication of this infection, which occurs as a sequel of that infection. That is the basic concept, the first concept that you need to understand. If you look for the presence of streptococcus in the lesions of acute rheumatic fever, you will not get them because it's not an infection, it's a complication of infection. This is the first basic concept that you need to understand. And nowadays, I would like to tell you this important concept that they have found that acute rheumatic fever can not only follow group A streptococcus pharyngitis, but it can also follow skin infection. In some studies, particularly famous one in the Fiji Island, recently they have found that, though uncommonly, but group A streptococcus skin infection can also precede the acute rheumatic fever. This is another key concept that you need to understand. And usually there is a gap between 2 to 3 weeks before a group of streptococcus infection occurs, pharyngitis occurs, and there is a development of acute rheumatic fever. And this 2 to 3 weeks is basically required because to mount that immune response. And from the immunological perspective, this is basically a type 2 hypersensitivity reaction which is associated with molecular mimicry. I'll be explaining this thing in the coming session. So it's basically it's an autoimmune reaction, the thing. So it's an autoimmune reaction, and from the hypersensitivity perspective, it's a type 2 hypersensitivity disease. This is another very important concept that you need to understand. Now, why acute rheumatic fever typically follows the infection of the pharynx? Because pharynx is a rich source of lymph node and lymphatics. So infection in that area can produce a much more pronounced immunogenic response. That is the basic idea that why streptococcal pharyngitis usually precedes the acute rheumatic fever. Now, what is acute rheumatic fever? There is no definite criteria previously for the acute rheumatic fever, and that's why previously Dr. Jones, he devised a set of criteria which is famously known as Jones criteria for making an accurate diagnosis of acute rheumatic fever. And those criteria which he devised then later get evolved and modified. That got evolved in 1992, and currently we follow the latest updated version which was created in 2015. And mostly these Jones classification, Jones criteria, they have some major criteria and they have some minor criteria for making a diagnosis of acute rheumatic fever. And there are typically 5 major criteria there, which are the 5 major clinical manifestations which are associated with acute rheumatic fever. One of them is principally the arthritis, which is typically polyarthritis. And they are migratory polyarthritis because they usually involve one joint after another. And this acute rheumatic fever typically involves the large joints like knee joint, hip joint, elbow joint. These kind of joints would be involved. Knee joint and hip joint, and the ankle joint, these are the more common joints which are involved in this. So, and another important fact is this, that they usually are very much responsive to salicylates and non-steroidal anti-inflammatory drugs, these arthritis. And they would usually pronounce, they would be responsive within 24 to 48 hours. And if they are not responsive to the salicylates and non-steroid anti-inflammatory drugs, you should be careful for making a diagnosis of acute rheumatic fever, because usually they always respond very promptly to NSAIDs and salicylates. Another key clinical manifestation is the presence of carditis, which is typically pancarditis, that is involving all the three layers of the heart: endocardium, pericardium, and the myocardium. And the most important pathology is usually associated with the endocardium, the endocarditis, because it can lead to the development of acutely also the valvular manifestation of acute mitral regurgitation and other things, which can be promptly diagnosed with the help of the echocardiography. And nowadays there is a concept of clinical and subclinical carditis, which has been introduced in this 2015 classification. Subclinical carditis means that you have carditis which cannot be auscultated, cannot be cannot be evaluated by physical examination, but if you do an echocardiography, you can see those changes in the heart. These are called subclinical carditis. The third manifestation is subcutaneous nodule, which is typically seen over the bony prominences, over the extremity, over the extensor surfaces. They are usually a painless mobile lump under the skin, and they are also regarded as a major diagnostic criteria for acute rheumatic fever. The fourth one, which I need to mention, is erythema marginatum. Erythema marginatum is a pinkish reddish macular rash, which usually have a serpiginous the margins. And another characteristic feature is this, that erythema marginatum usually typically do not involve the face. They can involve the body or the extremities, but usually they spare the face. This is another characteristic feature of the erythema marginatum. And they are evanescent rash actually. They appear and disappear promptly in front of the examiner's eye, it has been classically said. Fifth feature is the presence of Sydenham's chorea, which is a CNS manifestation of this. Sydenham's chorea is also known as Saint Vitus dance. That is a purposeless movement which is usually seen over the patient. And usually they are diagnosed with some characteristic sign like milkmaid sign, or a bag of warm movement of the tongue, protruding tongue. These are the features associated with this. So these 5 features which I mentioned are associated with acute rheumatic fever. One is the presence of arthritis, or typically polyarthritis. Migratory polyarthritis has been described. Second is the presence of the subcutaneous nodule, carditis, subcutaneous nodule, and the presence of erythema marginatum. And also there will be presence of Sydenham's chorea. And Sydenham's chorea is typically different from the other manifestation because it usually takes time to develop. Typically develops after 1 to 6 months after the history of infection. So this is usually a typically late manifestation of the acute rheumatic fever. And then there are some minor set of criteria are also there, like fever. And fever is usually very much high and pronounced in the case of acute rheumatic fever. There could be presence of some ECG changes like prolonged peer interval, which is typically associated with some conduction abnormality associated with involvement of myocardium. Then there could be presence of some increase in the acute phase reactants like increased ESR and increased value of the C-reactive proteins. This could be seen. So these things are actually not considered as the major diagnostic criteria, but the minor diagnostic criteria. And typically we require 1 major and 2 minor, or 2 major itself. This diagnostic criteria are enough to make a diagnosis of the acute rheumatic fever. Now, acute rheumatic fever is different from rheumatic heart disease. This one is another very important concept that you need to understand. Acute rheumatic fever is a multisystemic disease, and this has involvement of the various part of the body. So the cardiac manifestation of the rheumatic fever, that is known as rheumatic heart disease. So don't think that both are same thing, rheumatic fever and rheumatic heart disease, because rheumatic fever, as I mentioned, it's an inflammatory, immunologically mediated multisystemic disease which can involve the various part of the body, including CNS, including skin, soft tissue, and the joints. But when it involves the heart, that cardiac manifestation is explained by the term rheumatic heart disease. So this is another very important concept. And I would like to discuss about the rheumatic heart disease in the coming session, the other key concepts. Thank you very much.